Hi, my name's Naoum Issa from the University of Chicago Comprehensive Epilepsy Center, and I'm very grateful to both Erica and Kari from the Epilepsy Advocacy Network for letting me talk about this important topic, specifically the transition of care from pediatric to adult epilepsy care. There are lots of perspectives on this, but I think the most important perspective really is twofold. One is you're talking about a transition from one care group, the pediatric team, to an adult care group that has different teams, different approaches, and even different waiting rooms where the feeling is completely different. But I think the more important perspective really is the transition from going from parent-guided care to self-guided care for this young adult. And so that's a transition that has to be planned out. And I think there are very useful approaches to doing that. One of the most useful set of tools on this comes from the Child Neurology Foundation, where they've talked and planned out some of these transitional principles. And they've come up with 8 kind of common principles to help with transition of care from a pediatric to an adult environment. And we're going to go through a few of these, but I want to reference this as the main really useful source for thinking about this transition. The first thing is really when do you start planning the transition and what should you expect from it? And the answer, according to the Child Neurology Foundation, is you should start this pretty early in the early teenage years, between 12 and 14 years old. And you start sort of acclimatizing the child to the idea that they have to advocate for themselves and speak on their own behalf. And that includes having time during visits with their pediatric physician where the teen can talk without the parent present. This allows the child to have both some time where they can talk about things that they might not feel comfortable talking in front of their parents about, but really more importantly, so that they get used to advocating for themselves and talking about their own healthcare without their parents' input. I can tell you as a parent of young adults, it's surprising sometimes where the child thinks that they have made everything clear, but they've never actually said anything to the adult. And so part of the process is letting the teenager learn how to communicate that to the caregiver or the physician team, and having that start at, in the early teen age is a good time for that. The important thing to keep in mind is that at age 18, the physician really now has to have the young adults consent before they can actually speak to the parents about their health care. So having that transition process go on is a really useful thing early on. Now, it's often the case that in situations with epilepsy and comorbidities that a child won't actually have the decision-making capacity once they arrive at 18 years old. And so the expectation should be that all the legal processes and work that has to be done to maintain legal guardianship over that child should be done before 18 to prevent complicated transitions after that age group. The Neurology Foundation recommends that the full transition be completed by age 22, even though there are some transitionary components after 18. The second thing that they talk about is a yearly self-management assessment. And this is really talking about how a patient in their teenage years is being sort of quizzed and prompted to know their own healthcare information. So do you know your own medicines? What doses, what times do you take them? What are they called? Do you know what your allergies are? This can be very important later in life if they may not have remembered that they had a bad rash at age 7 when they started lamotrigine. But that has to be known, because at age 25, if they're now transitioning and they want to have kids and we say, well, the safest thing for you to be on is lamotrigine, if they don't know that they had a bad allergy to lamotrigine, they'll start over and they'll have a bad reaction again. Who would you call if you have a problem? And this is really important, teaching them how to use both contact information, MyChart, telephone, and understanding the difference between sometimes the hospital, the emergency room, and their physician's office. It's also important to engage parents in this transition, making sure that the parents know whether or not their child's going to be able to make their own decisions, and if not, what are the plans so that they can continue caring for their child? Will long-term care plans be needed? So when a child is 12 or 13, often the parents are still young and healthy, but by the time the patient's reaching 26, where they may now have to transition to their own insurance or different insurance plans, is there a plan for them to be insured? Is there a plan if one or both parents get ill or are not present anymore, to make sure that young adult or even the aging adult has some long-term care plans in place? The Child Neurology Foundation has some useful checklists and tools to sort of help with that assessment, and I encourage you to look at them. The next thing that has to be discussed is not just an assessment of the patient's ability to care for themselves, but also the ability for them, an assessment of the actual medical condition and the changes that happen in that medical condition with maturation. Discussion of medical side effects, of course, discussion of how well seizures are being controlled, a discussion of sexual changes that happen with puberty and maturation. Many of these affect women more than boys, but they're important to talk about. The effects of seizures, the effects of medications on oral contraceptive pills, the safety of medications in childbearing, vitamin care, and potential either genetic components to epilepsies, but also the effect of anti-seizure medications on a baby or a fetus. Driving is a very important consideration for teenagers as they reach 16 years old. I know in the city, many children, even without epilepsy, delay driving until they're 18 or 19, but in the suburbs or other places that might not be the case. And so people are lining up at 16. So you have to have the discussion at 14 and 15. Okay, what is the effect of having seizures? What is the effect of the seizure medications on your ability to drive and get that driver's license? Alcohol and substance abuse is an important thing to talk about with all teens, because almost all are going to be exposed to it in middle school or high school. But it's particularly important with epilepsy, where specific medications or specific drugs can worsen seizures. Alcohol use chronically or even acutely and binge drinking can affect seizure risks. So all these things have to be discussed openly and early. Psychological well-being is an important thing during high school and middle school, where stresses and interactions become very stressful, which can trigger seizures. But I also like to emphasize that epilepsy is a combination of symptoms. One of the symptoms that you can see is often seizures. The other one that you can't easily see is depression. And so depression is a very frequent comorbidity with seizures and epilepsy. And when you have the added stress of middle school or high school, that can get to be a lot. So that is something that should be discussed and actively treated if it's an active issue. The next formal thing that should be done is an evaluation of legal competency, and that should be started by the child neurology team right around 14 years of age in a discussion with the parents and caregivers to have an assessment of whether there's going to be an expected legal competency. This exam and assessment should be documented as part of the medical record. And if it's unclear whether there's going to be the ability to be legally competent at 18, this assessment should be repeated annually. Throughout the entire thing, we should hope to maximize the young adult's decision-making ability. So I don't think we should assume that they can or can't, but rather try to make it so that they have the maximum decision-making ability that they can. When it's decided that the child will probably not have legal capacity or competency to make their own decisions, the child neurology team in collaboration with social work and groups like the Advocacy Network should help the caregivers develop things like legal guardianship and powers of attorney so that there's no big surprise or crush right at 18. And then kind of the final stage is identifying and making the transition to a new adult provider. And I think when you're looking for a new provider, the first thing you should really do is assess expertise. So there are some sort of very common epilepsies, juvenile myoclonic epilepsies, focal epilepsies, that can be handled by a general neurologist or an epileptologist at a level 3 center. But then there are some kinds of subspecialty, very specific epilepsies, specific genetic epilepsies, devices where things are being treated by devices that you want to make sure that there's expertise in the group that you would be going to. Have you programmed or placed RNS devices before? Have you treated patients with specific rare genetic epilepsies, or do you have the genetic resources to help with that? I think an important consideration is insurance. If you're going to have to make a transition, you want to make sure that that provider takes the insurance so that you don't have a lot of out-of-pocket expectations or suddenly have to change at the last minute because they don't take your insurance. Location is important. I think now with video visits becoming very commonplace, it's less of a concern, but I do think that almost everybody wants to see the patient in person at least once at the beginning and then as frequently as possible, but you can have video visits. So just make sure that they can accommodate however you want to be seen. Availability is important, and meeting the physician and their team to assess fit is really useful. And the final thing I want to emphasize is that it's a team approach. A lot of times the emphasis is made on, well, did we like the doctor? The doctor, I think, is very important, but the team around that doctor is important as well. When you send a message or call, the first person who's going to be looking at that message is really the nurse. And if they can answer that question quickly and efficiently, they'll probably do that even without engaging the physician. So make sure that you talk to the nurse, you feel comfortable with their communication and how they address your concerns. And then there's often an advanced practice nurse. And once your child is stable, sometimes you'll be transitioned to see the advanced practice nurse for most follow-up visits, seeing the physician only infrequently. And that's okay, really, if if everything is stable and everything's working okay. So you want to make sure that you know who those advanced practice providers are and perhaps even meet them. Finally, what are you going to bring to that very first visit? And I think this is really useful to make it a smooth transition to the new physician team. The most important thing is a summary of the case that comes from the child neurologist. It's really helpful to see what tests were done, what medications were tried, when they had the best control, and what might be the next thing to consider if control isn't perfect. If you can bring a video of the child's seizure, that's really helpful. If there are different kinds of seizures, a couple of videos are useful. Bring all the medications in bottles to see what was formally prescribed, how it's being taken. Equally useful is a history of what medications were tried in the past and why they were stopped. Or do they have an allergic reaction? Did they have bad side effects, too much weight gain, whatever? Were they ineffective? Those are useful because if we're going to make any changes in the future, we want to not repeat as many mistakes as possible from the past. A family history is very useful, and a developmental history is useful. And oftentimes, the young adult might not know these well. They don't know who in the family has had seizures as a child or at other times. They also probably don't know their developmental history. Were they born early, late, on time? Did they walk it and talk in about a year? Did they have an individual education plan during schooling and so forth? If they've got devices, information about those devices, like when they were placed, what the programming settings are, who the representative was from the company that's been helping for like VNS, RNS, DBS, and so on. I know I like to see MRIs, original MRI data on discs. The report is crucial, but I really do like to see the MRI and have an MRI in our records. EEG reports are very useful, especially if there are multiple reports that have shown different things. It's good to see those reports. EEG on disc is a plus, but it's rarely feasible, so it's really not an expectation that we get those. If there's been genetic testing done, those results are crucial. They'll help plan out other changes and tailor management. And finally, if you have legal documents on decision-making capacity, power of attorney, things like that, those are very useful to have. There's several resources. Both American Epilepsy Society and the Child Neurology Foundation have resources, and you can either search for these or their URLs in this directly that have sort of recommendations for transitions. The Epilepsy Advocacy Network is a great resource to turn to. I know Erica has been and the other representatives have been very helpful and have a real depth of knowledge about how to navigate these things. So it's really good to have them on your side. And I look forward to taking questions. Thank you.